Thank you very much. It's a pleasure to be here in Seoul. Dr. Takata, that was a wonderful presentation. Very interesting, very well thought out. Enjoyed it very much. I wanted to thank very much the people who brought me here, Professor Yu, Mr. Yoon, and Yushin Chin, who helped me come here to Seoul to enjoy this 6th annual MTA Forum. I'm going to start out by showing you some photographs from a trip my wife and I took earlier this year in South America. We went to Chile, to the country of the big mountains, Patagonia. And what you see here are the famous 3 horns in the Torres del Paine forest in Chile. And it's a beautiful area, and if you ever have a chance, because we've hiked here in your country, in Korea, and it's a beautiful place, you'll see these 3 different horns. They call them the tres barcas, and they are gorgeous. And the land there is beautiful with a lot of lakes, wonderful place to travel. And if you get lucky enough, you get very close to the end area where the mountains are here, that 3 corners. And in the very back over here are a place called the 3 Towers. And I'll show you those at the end of the lecture today. So today we're going to talk about the multifaceted uses of mineral trioxide aggregate. And I'm going to show you cases where we're going to use them in surgery and trauma and also in vital pulp therapy. I live in downtown Los Angeles, and this is a view from my condominium. As I look out through the window, I see all these large buildings. But one thing about Los Angeles, it's very competitive. We have in California, the state I'm in, almost 1,200 endodontists. And it's turned into be an area which is basically an endodontic and implant war zone. It's a war zone out there. Everybody wants a piece of the action. Everybody wants to complete endodontics, and implants play a big part in this. So these are the type of cases that come to my office. Cases that are almost impossible to do. Perforation cases, overextensions, mobility. I'm asked to repair these kind of cases. Cases where you have external inflammatory root resorption, repaired 20 years ago with amalgam. A doctor comes to me, wants me to repair this. Almost impossible. Surgical failures with large periapical lesions. We also have cases with resorption, previous surgeries. Very difficult to do. Patients in their 80s with root caries. And cases where repair with amalgam has jeopardized the teeth to no end. Cases where you don't know what to do. And then we have the other factor, the implant factor, where implants are invading the area of normal teeth and causing failures. This is from a case from a colleague of mine in Washington. This patient came to him, he's an endodontist, for treatment of tooth number, this is for number 4 or 5. And the tooth was necrotic. And he told him that he needed root canal treatment. The patient disappeared and came back a year later. A year later, they had changed the restoration on tooth number 1-6, and what happened was he took an x-ray. So 1 year later, the patient came back and an implant was placed in this position of 1-5. Why? Because he told him that root canal treatment was not as predictable as an implant. Unbelievable. This tooth had irreversible pulpitis. That's the competition we have. And he was diagnosed with titanium deficiency syndrome. And this is what they call it in Los Angeles. Patient needed titanium. In 1996, I received MTA from Dr. Turbinajad. And this is what we had. We had it in a film canister like this. And MTA started out in my career, and thank God I have MTA because I've been able to save so many teeth because of this product. And what MTA is, it's a Portland cement, or better said, it is a calcium silicate-based cement. And there are many. It's a very competitive field. The patent for MTA was expired about 4 years ago, and we have a lot of competition out there. This is the proprietary material, the gray MTA, which I was trained to use at the beginning, using these types of carriers, 0.9 or 1.1 millimeters in diameter. Of course, they have white MTA, which still stain teeth, but still excellent product. We have bioaggregate, which is from Canada. We also have MTA Angelus and Biodentin. We have Endostem MTA from Korea, which is a fairly good product. And we have Endo Sequence Repair. It's made from brasswood in the United States. They call it a bioceramic, but essentially it's a calcium silicate-based cement. We also have Ortho MTA here from Korea, which is a superb product, which I've been using this year, along with Retro MTA. Great handling properties, quicker setting, no staining of the teeth, a superior product to the MTA I was introduced to 18 years ago. And we have a new product here, also in the United States. It's called MTA Plus, and it's made in Texas. So what is MTA made from? It's very simple. Different tricalcium silicate cements, tricalcium aluminate, tricalcium oxide, silicate oxide, some other mineral oxides. The proprietary material contains bismuth oxide, and that gives it its radio opacity, so you can see it on a radiograph. When we're looking at some of the experimental work done by Turgenev back in the 90s, the first case I saw was in 1993 when I was a postgraduate resident at USC Dental School. And what we saw was an experiment on dogs where they created perforation repairs. And what they did was they put a #1 burr through the furcas of these dogs and repaired them either with amalgam or with MTA. And then they sacrificed the dogs at about 6 weeks. And what we saw radiographically with the repair with MTA, we saw furcation bone that was stable. But with amalgam, we saw no repair at all. And why is that? Because amalgam doesn't seal very well, doesn't seal at all. And if you look at that histologically, what you see is something totally different we had not seen in endodontics or in dentistry before. What we saw with MTA, if you look very closely, and look at this histological slide from the dog, what we see is cementum repair. That's cementum right there. And by definition, if you can create cementum, it's supported by Sharpie's fibers and alveolar bone, you have true biological repair because this tissue is protected by immune-competent cells. In the old days at USC, when we had a strip perforation, we used to fill the teeth with amalgam and do a high resection. The problem is amalgam doesn't seal, so it doesn't work. These teeth were extracted because amalgam does not seal at 0 microns. Also, if we had perforations on mandibular teeth, what we'd also do is do hemisections. So there's a hemisection of a tooth, a mandibular molar, and this would be tooth number 3, 6, section in half. And here's a typical case sent to my office where the doctor asked me, please, Dr. Bogen, perform a hemisection. Well, I don't think it's going to work, but I did it anyway. So we performed a hemisection. Here's a 1-year recall. Vertical fracture. Not a good way to restore teeth, certainly. Dye leakage studies with MTA show that MTA is not sensitive to blood or to serum. That's beautiful. Not every surgery we perform in endodontics can you have this type of hemostasis, this type of clean area where you can perform surgery and have no blood. Most of the cases, even if you're using 1 to 50,000 epinephrine, you're going to have some hemorrhaging. In many cases, you're going to have profound hemorrhaging. And if you have a material that's not sensitive to blood or serum, you've got a material that can seal, you're going to have a much higher success rate. Also, if you look at the assessment of MTA as a root end filling material, they used it experimentally in a monkey model, non-human primates. And what we saw comparing MTA to amalgam as a root end filling material when these monkeys were sacrificed at 5 months was with amalgam, you saw this whole host of inflammatory cells. If you look at it closely, you've got PMNs, macrophages, neutrophils. Why? Because amalgam doesn't seal well, but more than that, it has an electrical charge. So the best healing that you're going to receive with amalgam is fibrous encapsulation. You will not get biological repair. With the monkeys where MTA was used as a root end filling material, you saw what? Cementum or a cementum-like material forming, Sharpie's fibers, and alveolar bone. A reformation or reformation of the periodontal ligament. If you compare marginal adaptation of MTA with IRM or with amalgam, MTA seals at 0 microns in resin models. This is very important because we have to deal with, in endodontics, these microorganisms. This is propiona bacteria. That's 1 micron, doctor. These are a half a micron, these bacterial cocci, gram-positive, usually involved in endodontic retreatment and disease. Classic study completed by Spanberg's group in Connecticut, where they took human osteoblasts and they grew them on MTA. Or, in this case, they grew them on IRM. And what happens? They die. If you try to grow human osteoblasts on amalgam, what happens with them is they thrive for a little while, but they also die. However, if you take human osteoblasts and you grow them on MTA, what you see is thriving, living cells. It's biocompatible. So what we have with MTA, material has these characteristics. It's not cytotoxic. It's not carcinogenic. Okay? It's not pro-inflammatory. It promotes cementum repair, and it's non-absorbable. Also, the material is hygroscopic or hydrophilic. That means if it's exposed to open air, if you were to leave the MTA on the counter in your laboratory, it will set and it'll look like normal MTA, but it will not set because it gets contaminated. Something that's very important. You have to keep MTA sealed in an airtight container. Solidifies in about 3 hours, great marginal adaptation, and has an alkaline pH. Very important, about 12.6. So what can we use MTA for? We have different uses for it. One of them, and the first thing we used it for, was for perforation repair. Now, I want to ask you doctors here in the room, how many of you doctors out here perform root canal treatment? Raise your hands. How many perform root canal treatment? Quite a few of you. How many of you doctors here in this hall have perforated a tooth while doing root canal treatments? Can I see some hands up? Excellent. The rest of you are liars because we all perforate teeth. It comes with the program. It's part of being an endodontist. You're going to perforate teeth. Here's the case for me. This was on a Monday morning. And I went in there. We had reversible pulpitis here, tooth number 31, which in here would be tooth number 47. Okay, I accessed it and it went right through the furcation. So we went ahead, repaired it with MTA, and then we completed normal orthograde root canal treatment. At this time, I was using lateral compaction, and here we have the repair with a bonded composite core. Here you can see another section. Nice clinical crown provided by a referring doctor. And here's a recall of that case at 3 years and a recall of that perforation repair at 7 years. And you cannot probe buccal or lingual into this area. That's an excellent result for a perforation repair. Here's another case. Look at this, how it presents to my office. You see this post here? That was placed by another doctor either on a Monday morning or a Friday afternoon, okay? You cannot probe the crestal bone up here. So we had that perforation site. So we went ahead, removed the post, and we placed an MTA repair after we retreated this premolar. And what you see here is a bonded core and no matrix. There's no matrix here. It's just pressed MTA against the granulation tissue. And here's a 1-year recall in that case. And I have, in my private practice, I have a private investigator who's a friend of mine who helps me find patients. So we tracked this patient down. He was in another part of California, and we brought him in for a recall. And here's a recall on that same case at 11 years. Probes, I was told it probes normally with great osseous mineralization here and retention and function of that premolar. There's a study out by Krupp right now. It's in the Journal of Endodontics, showing the success rate at 73.3% for perforation repair. And the reason it's so low in that study is because they also included perforations that were made at crest of bone. And that's a problem because MTA does not work when you try to repair at crest of bone. Here's a case of a 65-year-old male, and the perforation by the doctor, another doctor, was here right at the crest of bone. So we completed conventional root canal treatment, and you can see the perforation right over here, clinically. Orthograde root canal treatment, and a cast post and core, and this is MTA right here after the repair, but let's look at it 2 years. It is dissolved, it's gone. And the reason is because it wasn't protected by immune competent cells and it wasn't in solid bone. What other uses do we have for MTA? Certainly as a root and filling material, and endodontic surgery is something I was trained very well to do back at USC. And I like to avoid it if I can, but sometimes you can't. Here's a case of a lady from Beverly Hills who spent a lot of money. She has very nice aesthetic dentistry here, but we have a failing root canal treatment. I'm not going to re-treat this by removing the post and core. We're going to go straight ahead and perform endodontic surgery. And here is a 7mm MTA retrofill. Look at the lesion there. And here are some recalls of that same case at 2 years, at 4.5 years. These are typical cases that come to our office in Los Angeles. This case was completed by my wife, Dr. Lorraine Rowe, and she's an endodontist as well. And this is how it presented. We have transportation of the mesial root of this lower molar, number 3-6, surgical resection, MTA placement. You can see the osteotomy sites here on the radiograph. And here's healing at 3 months. Here's healing at 4.5 years. Again, another failing case, and we have a lot of cases here where the surgeries are completed with amalgam as a root and filling material. As I told you before, amalgam is not a good root and filling material. We have to resurgerize these. These are difficult to do, but with the surgical field microscope, we're able to remove the amalgam, replace it with MTA, and recall these cases with successful healing at this one 3 years and 8 months. What other uses do we have for MTA? Certainly, we can use it to fill canals in conjunction with apical surgery. Here's another case from Dr. Rowe. And this is a difficult case because here you have a silver point obturation with a broken silver point floating outside that root end. So how Lorraine approached it was to remove the silver point, which is easy when you have ultrasonics and you can trough around these cases. And here it is removed, and she opted to fill it with MTA obturation. She allows the MTA to harden, and then after it's hardened, she goes back in and surgically treats it, resects both roots, and she placed an MTA retrofill also in tooth number 1, 2. And here you can see that healing at 4 months. You can see some remineralization of that osteotomy site. And here's that same case at 2 years. And again, a recall at 4.5 years. And wait a minute, we actually got a recall on this patient came back. Here's a 9-year control with beautiful bone formation, full function of the teeth. And again, showing how bioactive and biocompatible MTA is. Now, this is a 15-year-old boy. Like I said, I live in downtown Los Angeles, but I practice in Hollywood, and I'm right near Martin Luther King Boulevard, which has a very large community of Afro-Americans. And this kid was hit on his bicycle at the intersection. Someone took out a few teeth, they left a few root tips here, but he came into my office with this huge lesion. And that's pretty scary, because as a dentist, what's the first thing you would worry about? Well, with a lesion this big, is that apical pathosis, or is this an osteosarcoma? Is this cancer? That's a worry. Well, what's the first thing you would do? The first thing you would do is test for vitality. This central incisor, number 2-1, was necrotic. So we went ahead, cleaned and shaped the case, placed MTA as a root end filling, filled MTA through the entire canal system, and we waited for it to harden. And if you wait for it to harden and then resect that root end, it does not affect the seal of the MTA. That's been shown by Anlin and Lamb. So we went ahead, completed the resection during surgery, and here's a recall. And I love young children because they heal up so well. And here's that case at 1 year with complete remineralization of that area. The biopsy from the pathology lab came back as a periapical granuloma. Thankfully for that young man, he didn't have cancer. And I get calcified cases. You can see a canal here on tooth number 3-6. Can you see canals over here? Well, we get our microscope out and we use our small files, number 6, number 10s. We try to find these canals. And here I am halfway through and I'm thinking, oh, I'm going to find the canal, no problem. So I keep working and I keep working, and finally what happens? I perforate it. I perforate it trying to find the canals. So what's our option in these cases? Simple option. Go ahead, complete MTA obturation, and that's MTA in the distal canal, place a post and core, then we go in and complete surgery after the MTA is hardened. These are markers on the cortical plate so I know where I'm going in so I don't resect the wrong tooth or the wrong roots, of course. And here's that resection. In this case, this particular molar had an isthmus. The occurrence of an isthmus on mandibular molars is about 25%. So there's going to be isthmus between the mesial buccal and the mesiolingual roots. So we had to place another retro here. But look at the healing here. Here's that case about 2 years later, and complete function and remineralization of the osteotomy site. I work at the Children's Dental Health Clinic in Long Beach. We had a case come in 1 year, and this was a young man who had had a trauma. His child was about 10 years old, and they had horizontal fractures right here of the central incisors. Somebody, another doctor, had gone in and completed obturation of these two central incisors all the way to the apex. The problem is, in these types of trauma, the fact is, these apical segments, these are alive. You don't have to really fill this segment. You can fill it right to the horizontal fracture. Regardless, he had a failing case. So what happened? We tried to retreat it with MTA. So we take the gutta percha out, and here we still have pathosis. And that lesion did not go away. So we had to surgically intervene. So in surgery, we went from the buccal plate, and we removed the gutta percha from this area, and you can see that healing after about 2 months. And here's that same case with some poor cores that one of the residents placed. I didn't place that, but we have good healing here at 3 years. But let me digress for a second. I mean, many of you being general dentists, you're going to see traumas. Traumas are typical in children, especially aged 10 to 12 years old. Here's a 4-year-old child, and here's a horizontal fracture. So do we need to treat this tooth? Well, actually, you need to splint the teeth together, which is what we did. And with splinting, it's amazing how strong the body's repair process is. Look at this. This is at 6 months. And look at this repair here. We have repair already without any endodontic care at all. Just splinting for, in this case, it was for 8 weeks, and we left it on for 6 months. Here's another case, 12-year-old, trauma, horizontal fractures, splinted for 6 weeks. Now you can begin to see repair. And this type of repair that the body performs is made of osteodentin or cementodentin. No endodontic treatment at all. Look at the repair here, and this is 2 years later. But I've got a fantastic case for you. This is a friend of mine, Paul Anstey in Beverly Hills. This patient presented to his office. This is a 12-year-old male who had a horizontal fracture and a separation of these two segments. He splinted the teeth together for 6 weeks. And look at this recall. Here's a recall at 7 years. That is either osteodentin or cementodentin repair. This is how it looks clinically. You can probe it. It probes 1 to 3 millimeters. And here it is at 10 years. So the moral of the story here is sometimes as doctors, let the body heal. The less we do, sometimes the better off our patients are. This is a case of a nurse who came to me who had root canal treatment completed by a general dentist in Los Angeles. She's a nurse at Cedars-Sinai Hospital. And the root canal treatment was completed by the general dentist. It's pretty good, not bad, but it didn't heal. So we retreated the case with MTA. And here's my final file. We pushed a little bit of gutta percha out the apex. And here's MTA obturation. And here you can see it with a gutta percha backfill and a composite core. But at 6 months, it didn't heal. It just wouldn't heal. So we completed surgery and took a biopsy. Now, why didn't it heal? Well, we have other factors in endodontics that preclude healing. And what can those be? There's 2 different things it can be. One are biofilms. Biofilms are exopolysaccharide matrix embedded bacteria that live outside the root end. These are courtesy of Dominic Reccucci. Domenico is in Italy. He's an excellent endodontist, and he also has a laboratory in the back of his office where he stains tissue and shows different modes of failure in endodontics. That's a biofilm, doctors. Look at it very closely. So you have a polymicrobial community of bacteria, possibly yeast, possibly viruses, living in this exopolysaccharide matrix. Immune to immune cell phagocytosis and antibiotics. In the case of this woman and that surgery, it turned out to be the other problem we have in endodontics, and that is extra-radicular bacteria, actinomyces, and that's what this was, actinomyces case. And after surgery, we see great healing at 1 year, and here's a recall of that same case at 3.5 years. What are you going to do here? How are you going to treat this? How can you retreat this? Can you get these files out under a microscope? No, impossible. You have to see the head of the file. There's 2 files broken here. So our strategy here with cases like this at my practice is we're going to use MTA obturation. So we're going to fill it with MTA, and then we're going to wait for it to harden and then perform surgery. In this case, there was no isthmus, and here's that case right after surgery. And here it is healing at 4 months. And we have a few recalls, 3-year recall. And again, a good year recall here at 7 years. And one last case here. Typically, these type of cases, when they come into my office, these patients have been told they need an implant. Dr. Bogen, can you help me? I don't want an implant. These are hard cases, but with MTA and with a different strategy, we can actually save teeth like this. Retreat the tooth by removing the posts, filling the canals with MTA, placing a post and core, and then surgically going back into the site, removing the amalgam and removing the snow around the amalgam the best you can, and we put MTA root end caps at the end of the area. There was resorption there. And let's look at this case here. This is a recall with a crown at 6 months. And here's a recall of that same case at 8 years, 3 months, still in full function, and the man did not have to have an implant. Other clinical uses are apexogenesis and apexification. Apexogenesis is the formation of a new root. Apexification is the formation of hard tissue barrier against an open apex. Here's a premolar on a 12-year-old with a dens evaginatus and a necrotic pulp. Place MTA, and here's a recall of that same case at about 18 months. We have a lot of cases like this where you have, and it's very typical in Asian populations where you have dens E. vaginatus cases. Here's an open apex, it's necrotic in a 15-year-old boy. Again, 7-month recall, and look at that formation and maturation of that root at 7 months. This was an avulsion case. This tooth was knocked out. Extraoral time was about 15 minutes, replaced into the socket. We completed cleaning and shaping of the case and provided for this person, this was a 7-year-old, an MTA plug here. And look at this type of reformation or apexogenesis. 1 year recall of the bonded core, and here we see some development here at 3 years. At 6 years, 3 months, again, 11 years. And here's a recall at 14.5 years. It's not a perfect root, but it is a form of apexogenesis, and the patient maintained the tooth in full function, and that's one happy patient. But if you want to see an apexogenesis case, my mentor is Dr. Turbenejad at Loma Linda. He's the inventor of MTA. And here's a case from Mahmoud's practice. So he has this young man come in, and this is another case of a dens E. vaginatus, open apex, about size 400. He placed MTA in this case, and I believe the patient was 9 years old, 8 or 9 years old. That's a size 400. This was his operation with MTA, and then he lost the patient in recall. He didn't know where the patient went. 5 years later, one of his doctors calls him up and said, Dr. Turbenejad, I have your patient in my chair. I have something unbelievable here. Well, we'll send him back over. So the patient came back to Dr. Turbenejad's office, and he took an x-ray. And this is what we saw. That is apexogenesis. That is a reformation of that tissue to a very high biological extent. So let's talk about filling teeth with MTA. MTA obturation, as we call it. Something that we think is new, something that we think is relatively innovative. But that's not the case. There was a doctor in Germany, Dr. Witt, back in 1878, 136 years ago, that was doing what? He was using Portland cement to fill teeth and a pulp cap with, back in Germany, back in Hanover. Now basically, calcium silicate-based cements are Portland cements. MTA, ProRoot MTA, Ortho MTA, those are basically Portland cements. And here's his original article from Hanover, 136 years ago. Because we know that gutta-percha leaks. Here's a classic study from Baumgartner's group in Oregon. And what they found was they compared laterally compacted gutta-percha with warm vertical. And what they found is that warm vertical does not leak as much as laterally compacted gutta-percha. But against bacteria, guess what? They both leak at the end of a 30-day test period. And that's why all these companies want to sell you a product that replaces gutta-percha. From Resolon to Endofil, these are all companies trying to replace gutta-percha because what they want is they want gutta-percha-free endo. They're going to try to make money, but they're going to say, this is better than gutta-percha. But even better than gutta-percha may be MTA. We know if gutta-percha is challenged by bacteria, Madison-Wilcox study showing that 15 millimeters of gutta-percha leaks in 3 days when exposed to bacteria. Because these culprits, which cause endodontic disease, are so small, this Peplostreptococcus, that they can get between the gutta-percha, the sealer, and the dentinal wall quite easily if it's not sealed by a good restoration. Now, MTA has these characteristics. It forms this interstitial layer with dentin that looks like hydroxyapatite on X-ray diffraction studies, okay? Teeth operated with MTA actually increase fracture resistance, okay? MTA has a very high clinical pH that's extended, it's 12.6. Also, MTA provides fine particles which can occlude the dentinal tubules. Dentinal tubules being what, about 2.5 to 3.5 microns. It also inhibits the growth of these very, very challenging bacteria, Enterococcus faecalis and Candida albicans, which is a yeast. Also, MTA is osteoinductive and cementogenic. It produces bone reformation, and as you've seen, it produces cementum repair or a cementum-like material. An interesting study that was completed by Roberto Holland in Brazil. He was comparing a modified glass ionomer cement with MTA and was filling teeth in dogs. And after he had obturated his teeth with dogs, he sacrificed the dogs at 5 months and looked at the histology. And what he saw in the dog model was, frankly, quite revealing. What he saw was at 5 months, this is MTA obturation, what he saw was cementum growing into the main canal. Here's Sharpie's fibers, and here is alveolar bone. Not only did he see cementum growing into those main canals in those dog models, he also saw cementum growing into the accessory canals. So we have a very, very good obturation material here that promotes this type of repair. And the particle size of MTA is excellent for occluding those dentinal tubules 2 to 5 microns. 88% of those particles are the right size. This is from Marcus Hopsolo. He's a very well-known educator from Canada. He does a lot of work. But look at this SEM. I call this hotel bacteria. These are dentinal tubules completely occluded with different types of microorganisms. And when you have retreatment, when you've had cases that are failing root canal treatments and they're contaminated, what do you think they look like at the apex or inside those dentinal walls? This is what they look like. They're full of colonized bacteria. So if we have a product that we can use to fill these dentinal tubules, and it seals them completely at 0 microns, and we have a material that has an extended pH at a higher level, we can entomb these bacteria and we can eliminate them. And this, doctors, was eloquently done by a study here in Seoul, Korea, by Dr. Koom, Dr. Yu, Dr. Chang, and some other authors. This study was excellent. And what it shows is this remineralization of these dentinal tubules with bacteria actually entombed them quite predictably. Let me show you some of the SEMs from the study. So what they did, they contaminated bacteria in the dentinal tubules, placed MTA alongside, and you can see at 1 week, 2 weeks, 3 weeks, and at 4 weeks, you can see this entombment of the bacteria by mineralization. And you can see crystallization all the way to the apex. This is a great way to retreat failing root canal treatments and eliminate the challenge of bacteria like Enterococcus faecalis. And what's the other problem? Well, guess what? Root canal treatments are not that easy, doctors. Look at these teeth here. These are mandibular molars, and these are the mesial roots of mandibular molars. You who perform root canal treatment say, well, I deal with those all the time. That's not very challenging. Let's take an x-ray. Let's look at the anatomy here. If we take an x-ray of these teeth, this is what the x-ray would show you if you could see these canals. Can you operate that? Yeah, that looks pretty easy, doesn't it? Sure, we can all do that. Let's take a micro CT scan. Let's look at it a little differently. This is what the anatomy looks like, doctors. This is complicated. Are you going to be able to fill these canal systems with gutta percha? It's going to be very difficult. You're better off having a material that can seal at 0 microns and has a really high clinical pH. These are the apices of these molars. Do we have 1 foramen? Do we have 2 foramen? Some of these cases, some of these teeth have 12 apical foramen and accessory canals at the apex. How are you going to be able to fill these with conventional gutta percha? It's very difficult. Look at this micro CT scan. This looks like a molar that you and we could treat. 4 canals, maybe 3, we don't know. Look at the micro CT scan. Here we have a molar that has 2 mesial canals, 4 portals of exit here. The distal canal, you have 3 canals, 1 canal dividing into 2. Those are very difficult to handle technically, and certainly if we have a material that's a lot better at eliminating microorganisms, we're going to have a better outcome for our patients. This is a holistic doctor. I have many people in Los Angeles that are in the movie business, and they don't want their teeth filled with gutta percha. They look at the internet and they say, well, you know what? It could cause an infection later. I want my teeth filled with something more natural, something that's a higher level. So the option for me at my office in Los Angeles is obturation with MTA. So this is a medical doctor. He came in here with a large periapical lesion. He was symptomatic, and we completed root canal treatment. But instead of filling this with gutta percha, we filled this with MTA. This is back quite a long time ago. This is gray MTA, restored with a gold crown and zinc phosphate cement. There's a 6-month recall. You can see the resolution of that apical pathology in 6 months. But look at it 3.5 years. There's no pathology at all. And I managed to bring that man back for a recall here at 9 years and 8 months. Here's a nurse who also didn't want gutta percha obturation. She opted for MTA. So here's an MTA obturation completed. And don't let anybody tell you that the apical foramen is 0.5 millimeters from the radiographic apex. That's not always true. Here's the mesial canals of this molar. Number 3, what is this, 3.7. That's almost 4 millimeters from the apex. Here's the obturation, sent back to the general dentist to have a core placed. And here's a 4-year, 4-month recall showing furcation, bone remineralization, and complete function of the tooth. And one more case here. This is a movie star. These guys also do the research. They don't want to have gutta percha filling. So this is an MTA obturation sent back to the general dentist for posting and coring. The patient received a cast gold post and core and then a gold crown. And here's a recall at 4 years, 4 months of this molar, number 4.6. And here we have that case, and here's a recall of that case at 12.5 years. This is my oldest MTA obturation case. And I routinely now in my office, if I have a retreatment, I have a failing root canal treatment already, I'm going to take the gutta percha out, it will receive MTA only. I don't do gutta percha retreats anymore. And if you're rich like this guy, and you've got a lot of money, and you've got a Learjet and a few houses around the world, well then you can have crowns made like these, with diamonds in them. Don't ask me why, but this is what the man wanted. And he's pretty handsome, but he's definitely got a lot of bling, as we say. Ingrid Lawati is a lady dentist. She's up in Santa Barbara. She used to work with a fellow named Steve Buchanan, and she probably does the best MTA obturations that I've ever seen in my career. Here's some of her work, and certainly in this textbook that we have, that you have now translated into Korean, on the chapter of MTA obturation are several of her cases, and they're absolutely beautiful. She does a great job, and they look better than gutta percha obturations, but she knows how to handle MTA better than most. She's very good at it. MTA can be used too for anatomical anomalies. We don't get these often, but you get these cases where they have not formed properly, and you get dens evaginatus or invaginatus, okay? Here's a dens evaginatus case on a 14-year-old boy. Look at this pathology here. It's quite extensive. But what we did was we decided to fill it with MTA. This was an MTA obturation. And the way we do this, in this case, we used something called a auger technique. And what we do is we take a NiTi file and we run it in reverse. We run it the other way and press down on it and pack it using a NiTi file in reverse. And this is what happened on this particular case. And look at this pathosis. At 2 months, 1 year recall, complete remineralization of that pathosis using MTA as the obturation material. On a case like this, if I were to fill it with gutta percha, the chances of it healing may have been 50-50, and I would have had to perform surgery. In this case, as you can see with MTA, we have excellent periradicular healing and resolution of the pathosis. Here's another unusual case. This is a gentleman who came in, he's got a talon cusp. In this case is a dens invaginatus or dens indente. Here is the radiograph, and you can see it here on a sandwich shot. Let me show it to you here. You can't see this very well on this particular projector here, but what we have is a talon cusp and a small dot right there where that is the portal of entry. And we have a necrotic pulp on this young patient. And here's what it looks like. And the first thing I did after I accessed this tooth, and we accessed from the buccal, and look at the relationship here to the maxillary arch. The first thing I did when I went in, what do you think I did when I went in through the buccal? The first thing I did was perforate it. Of course, perforation. It happens to all of us as endodontists. Here's a radiograph after a perforation repair. This is where we perforated. Here are the actual main canals accessing from the buccal aspect of this patient. MTA obturation. And here you can see the perforation repair material. And there's the canal obturation material on this patient. Very difficult patient to work on. But if we recall the patient, here we look at that open apex. And here's that apex again at 2 months. And here's an obturation of that apex at 1 year. Look at, you can see that formation again, apexogenesis or maturation of that root end in this young patient. All we were able to get was a 2-year recall on him. He's disappeared on me, but I'd love to have him back for a 8-year recall one day. And here's another case. We have this funny looking tooth. And this was a young man, 12 years old. Another case of dens invaginatus or dens indente, a tooth within a tooth. We have to clear through this dental bridge into this apical compartment. We complete, this was calcium hydroxide, which I don't use anymore. When I'm completing teeth with MTA obturation, I no longer use calcium hydroxide. There's no need for it. It's not necessary anymore. And here's that case with MTA obturation, a bonded core buildup, and recalls here at 3 months, at 1 year, and I believe we have recalls here at 2 years, and one recall at 7 years. From here to here at 7 years, complete function of the tooth. Other uses for MTA also include canal obturation in retreatment. And this is something I do now routinely. If I have a failing case with MTA, I know I'm going to get healing. Here's a failing case, large lesion. The patient was told he needed an implant. Went ahead, completed obturation with MTA after cleaning and shaping. Here's an MTA plug. Restored by our office, crowns by a general dentist. Look at the repair here at 2 years and 8 months. And here's the case at 5 years, 6 months. The patient, this was in 2013, the patient came back this year and he had swelling in the vestibule. And the general dentist said, hey, Dr. Bogen, your case is failing. You got to fix this. So he presented and he looked like this. He had swelling across the vestibule all the way over to tooth number 6. So we took an x-ray and guess what? Here are the 2 teeth we treated with MTA. What do we have here? We have a failing implant. It's funny how fast the doctors think that the retreatments fail when in fact implants fail all the time. 15-year-old boy with a root canal treatment completed at a clinic down the street. Look at the amount of this pathosis. So in this case, MTA retreatment is indicated. Remove the gutta percha, clean and shape the case. And here it is with the MTA obturation. We leave an area of gutta percha here, and then we fill this with a composite core. We leave gutta percha here because down the line, the patient may need a post placed there, and gutta percha is a little easier to remove than MTA. MTA, you would need a surgical field, microscope, and an ultrasonic device. But look at the recalls on this. There's a 3-year recall. Look at this healing in that mesial area. And recall in that same patient here, and that's at 7 years with no surgical intervention. Other cases, we'll show you here root resorption, and we have external and internal root resorption. These can be quite challenging, but here's a typical case. This is external inflammatory apical root resorption on a 28-year-old male. And rather than filling it with gutta percha and maybe having to electively perform surgery, it's better to place, in this case, an MTA plug, as you see there, with a backfill of gutta percha and a bonded core. And if you look at this case here, we have fairly good healing at 7.5 years without surgical treatment. Sometimes I get resorption cases that are very difficult to handle. This one here, look at this resorption here, right at the CEJ. Those are the tough ones. We retreated both these teeth with MTA. And here you can see this with a bonded core, as with this one. And we recall this at 2 years. And what we saw was an implant, because MTA cannot resolve every type of pathosis. And also, if MTA is exposed to the oral environment, which I showed you earlier, it will dissolve and will not provide a seal. Good case from my friend Mark Olson in Canada. The patient was told they needed an implant in this case. He called me up. He says, George, what should I do? I said, fill it with MTA. You have nothing to lose. They're going to place an implant. Do an MTA obturation. So Mark went ahead. He placed MTA. Here's the MTA obturation on tooth number 1-1. And that's a 1-year recall with complete reformation of bone, no mobility, complete function of the tooth. That's pretty good healing. This is a case I had. I get these people come in. This is a male patient in his 30s who had root canal treatment provided for him 2 years before. And he had the root canal completed, and the cavit, the temporary material, fell out. He ran around like this for 2 years until the decay went into the chamber and right through the furca and blew out the furca. And there's a lesion. You can see it here. And we've got a tooth that traditionally you would look at it clinically and you'd say, that's an extraction. We can't save that for you. But aha, that's not the case. Get a microscope out, get your caries detector out, clean it out. That's what we did. The decay is going right through that furca. So we cleaned it and shaped it. I placed MTA. I got a whole bag, a whole gram of MTA into this tooth. And I told the patient, I'm going to put a core in this, and if you come back in 1 year and it probes normally and it's not mobile, I'm going to say you can get a crown on it. He comes back a year later, and guess what? It healed up. And here it is. It's not mobile. You can probe it, no more probing. He puts a crown on it, and we got him back for a recall at 2.5 years. And here's that same tooth in complete function with no pathosis, asymptomatic. And that's what I call my MTA implant. And let's talk about vital pulp therapy here. Vital pulp therapy, that's a broad term. And it includes direct pulp capping. It includes indirect pulp capping and pulpotomy, and partial and full pulpotomy. I'm not going to talk about indirect pulp capping because that's left for an expert in Denmark, one of my colleagues, Lars Bjørndal. He's in Copenhagen, and I'm going to be lecturing for their group next month, and I'll leave that part of that lecture to him. But why do we consider saving a living pulp? And the reason is simple, because teeth that undergo root canal treatment, posting and coring, and cuspal coverage restorations have a lower survivability than teeth that maintain living pulps. Here's a root canal treatment completed by Dr. Dudley Glick at the USC Dental School in 1955. The patient came to me because she had a palatal sinus tract. We retreated this tooth last year. I still have a recall coming up just before Christmas, so I couldn't present it to you today. But doctors, this is a 58-year recall. Root canal treatment works, even if you're using silver points. But root canal treatment is also abused. This is a 12-year-old boy who received a thermofill obturation. We have a separated file here, and the doctor didn't know you were supposed to put a temporary in the tooth. He thought there was nothing wrong with that. This was a court case I was involved with. This tooth was extracted, but it could have been saved. But root canal treatment is abused. I try to save teeth, and a lot of times you get cases that have been breaking down for years. This is a 28-year-old female who had received a root canal treatment 15 years before with silver points. So I went ahead, completed an MTA obturation, removed the silver points, and it looked good in 2003. The patient returned with a vertical root fracture of tooth number, and this is tooth number, what, 2-6. Okay, so what did we perform? She wanted to keep the tooth. Only option we had was root amputation. So we amputated the mesiobuccal root, and the dentist downstairs went ahead and put a beautiful crown on it, and it was functioning for her for several years. In fact, she came back for a recall. That was 2006, and here she is, returns for a recall 2011, still functioning well. However, 6 months later, she returned, and bam, catastrophic failure. So she got 8.5 years of function out of the tooth, but again, root canal treatment lowers the survivability of the teeth. Also, root canal treated teeth show a higher incidence of plaque-related factors because you're replacing a God-given part of the body with an artificial crown. And crowns aren't as good as the actual crown you were born with. Also, patients who receive root canal treatment lose proprioceptive mechanisms. Patients who have root canal treatment bite 2 or 3 times as hard on a hard object before they feel pain. So if they bite on a peppercorn or a cherry pit or an olive pit, they can crack those teeth quite easily. So even though root canal treatment can prolong the retention of the tooth, root canal treatments shorten tooth retention. But the implant guys will tell you, oh, no, implants work much better than root canal treatment. You need to buy our implants. There's a big business in America selling implants, and I don't know what it's like here in Korea, but I know as a human being, I'd rather keep what I was born with, because implants suffer from what? Peri-implantitis, loss of bone around implants, and we see it all the time. These are a couple of cases I picked up just last couple of months. These came through my office. These were apart from my endodontic treatment, but here are a couple of failing implants. Because the people who sell you implants quote studies from Shimon Friedman's work showing low success rates in endodontic retreatment and endodontic surgery. But these are the implant studies that the implant companies don't want you to know about. Peterson's study showing an 89% success rate at 10 years. DEMA study from the Mayo Institute in New York, 86% success at 20 years. These are with implants. And the recent study, the Silva study, at 4.2 years, a success rate, 81.3% of implants placed in general practice, not in an academic setting, not by specialists, just by general dentists. 80%. That's not very high. But if you look at a comparison of root canal treatment, retreatment, and surgery compared to implant success rates, you know what? They're about equivocal. Equal turbinogenic studies, outcomes for endodontically treated teeth and implants, no statistical difference. So if you tell your patient that retreatment or surgery doesn't have a good prognosis, you're not right. The prognosis is just as good as it is for implant placement. And certainly that should be your first option. So what if we do have a pulp exposure? What do we do when we have a pulp exposure and we're trying to save that pulp? Well, the pulp has an inherent ability for repair as long as you can remove the bacteria and prevent microleakage. Because what we're trying to save and what we're trying to induce are these odontoblasts, which line the periphery of the pulp from the apical area to the pulp horns. And these odontoblasts lay down reparative dentin during the lifetime of the tooth. Charlie Cox in his studies on non-human primates showed that the deeper you cut a class 5 preparation into the tooth, the more reparative dentin formation occurs. And the odontoblasts lay down reparative dentin at a rate of about 1 micron per day, which means at a year and a half, you may have 500 microns or a half a millimeter of reparative dentin formation. Look at this premolar. It has a class 2 amalgam here, but look at the reparative dentin there. It mirrors that class 2 because restorations are trauma to these teeth, and the odontoblasts respond by forming reparative dentin. Here's a caries cleanout on a molar. That is all reparative dentin sitting on the roof of that pulp in that patient. Or look at this patient. Here's after a caries cleanout. Look at that reparative dentin. It's in the shape of the pulp chamber. The pulp has a great ability to protect and repair itself, especially with dental caries. Dental caries produces 80% of endodontic disease because the pulp has innate and adaptive immune responses that protect it when bacteria challenge it. So before the caries exposure, the innate system protects the pulp from the bacteria entering. Once they enter the pulp, then the adaptive immune system takes over. So this is from Marcus Hopasalo, and here is dentin with bacteria challenging the dental tubules. But what happens is the dental pulp has this innate ability, and the first thing that these acidogenic bacteria are faced with is a positive outward flow of dental fluid, which contains immunoglobulins and serum proteins that slow bacterial diffusion. Secondly, the odontoblasts themselves have toll-like receptors, and these promote pro-inflammatory cytokines. And these cytokines lead to neuropeptide formation. Neuropeptides increase vascular permeability and increase interpulpal pressure. This leads to nerve sprouting and eventually neurogenic inflammation and painful pulpitis, which we know about as endodontitis. Also, you have innate immune cells, cytokines, and chemokines that participate in that innate response. This is again from Dr. Recucci in Italy, and you can see caries in that molar and the bacteria going through the dental tubules, and that response within the pulp can be seen as far as 2 millimeters deep within the pulp. Close section here, and you can see that bacteria coming out of that dentin. And here is bacterial colonization, and it's that point at which everything changes from reversible to irreversible pulpitis. So as soon as the bacteria are able to colonize, that's where you're going to have a change in your diagnosis. And here is a case of a pulp that is almost necrotic, and look at this bacteria invasion here with pulp stone formation. That's when the adaptive immune response occurs, and that produces, of course, inflammation, and you get different types of interpulpal pressure increases, abscess formation, and eventual pulpal necrosis. And as an endodontist, you have patients that come to your office, and they've got bad toothaches. It really hurts, doctor. I could not sleep for 2 nights. And here's how it presents. And when you put anesthetic on board, a dental dam on board, and you open up the tooth, what do you see? It explodes. The pressure is quite high. Sometimes I've had cases where the hemorrhaging, I couldn't stop it for a half an hour. Painful pulpitis. Obviously, you're not going to be pulp capping a case like that. So if we can intervene early enough to remove those antigens, we can prevent irreversible pulpitis. So when we're excavating caries, and we're doing it carefully, what can happen? We can have a pulp exposure, okay? When we have a pulp exposure, what are we going to do now? So let's talk about advanced pulp capping techniques. One thing I talk about is, you see these 6 radiographs here? These are radiographs from patients age 7 to age 40. And if you agree with me, they have 2 things in common. And the first thing, I think you'd all agree with me, is that they have what? They have deep caries. But they have one other thing in common, and that's this. these were all referred to my office for root canal treatment. They were diagnosed on a radiograph. How can you diagnose pulpal conditions on a radiograph? You can't. The bottom line is all these were vital pulps because no one bothered to cold test these teeth. These teeth responded normally because we have something in endodontics and dentistry we call differential diagnosis. You have to have the patient report. Look at the x-ray, check the mobility, look at the patient age, and most of all, test the vitality with a cold test. Those were all vital pulps. Of course, when we're performing vital pulp therapy, I want to make sure the radiograph looks normal, the cold response is normal, and some other factors are important. This molar here, number 4-6, obviously, it's got furcation lesion, it's got a periapical lesion. You're not going to pulp cap that tooth. But when I do and perform pulp capping treatment, I use some technology by an old Japanese professor who's quite famous. His name's Tokei Fusuyama. And he found out that caries removal varies from patient to patient, doctor to doctor, and he developed something called a caries detector dye, which Dr. Takada talked about earlier. We use this. And why do I use this under a microscope? Quite simple. When you have caries, you've got two types of caries. And the pioneer bacteria here, which produce lactic acid, break down hydroxyapatite and collagen in the outside layer. But the inside layer, hydroxyapatite's broken down, but the collagen's still intact, and it will not stain with the caries detector. Therefore, the calcium phosphate from the pulp will come to this area and remineralize that area, further protecting the dental pulp. A caries detector dye is an objective way to remove caries and to protect the pulp. I use that routinely. Now, if I have an exposure, what am I going to do? Am I going to use sterile water? No, I'm going to cut to the chase. You can use all these as hemostatic agents in vital pulp therapy. Bottom line is I use, and my colleagues use, sodium hypochlorite to stop hemorrhaging. 6% to 8% sodium hypochlorite. And the advantages of that include, obviously, it's going to stop bleeding, it's going to clear the dental chips, amputate the blood clot, and remove the damaged cells from the area and disinfect the interface. The Japanese knew about that over 50 years ago. Suda and Hirota were using sodium hypochlorite for hemostasis back then in the Tokyo Dental Journal Bulletin. So if I have an exposure and my pulp is bleeding like this, if I place bleach on there for 5 minutes and it stops bleeding, what does that mean, doctors? That means my diagnosis is irreversible pulpitis. One of your best diagnostic tools you could ever use in vital pulp therapy is bleach. Because if you can't get it to stop bleeding with bleach, guess what? Your diagnosis is incorrect. The diagnosis is irreversible pulpitis. It's so inflamed you can't stop it. Now you have to be more aggressive with your treatment. So let's look at a couple of cases here. Here's a young patient, the one in the middle. That is a 7-year-old patient. What's it look like clinically? Let's look at this case clinically. Deep caries. It's not pretty. So we use a microscope, caries detector dye. Here's halfway through. The dye has to be applied 6-7 times. Here are the exposures. These are all the pulp horns. But what do you see over here? You know what that is, doctors? That is reparative dentin. So this pulp, these odontoblasts have been working to protect that pulp from that ingress of bacteria. Here's your reparative dentin. This is a healthy pulp. Why? Because I stopped it from bleeding and the tissue looks normal. So what do we have? We have contemporary materials here in pulp capping. And mineral trioxide is what I'm using, but very rapidly. I used to use hydrophilic resins, modified glass ionomer cements. Here's a case of an exposure on a 15-year-old girl that I completed using Photobond many years ago. That was back in, 2001. And we saw reparative dentin formation at 2 years. And here's actually, she's a daughter of a friend of mine. And here's a recall at 15 and a half years. It worked. The problem with those resins, they're not predictable. Silva showed a lack of biocompatibility and the resins are very cytotoxic to the pulp recently. Also, Nascimento study in Brazil showing that resin-modified glass ionomer and liner bond do not promote bridge repair in humans at 300 days. Calcium hydroxide, the old gold standard for pulp capping. Certainly, the study by Demishki showing a good 80% success rate up to 16 years is one of our classic studies on it. But Charlie Cox's study on non-human primates, on monkeys, show after 2 years that calcium hydroxide leaves these pores in the dental bridge, tunnel defects. And the tunnel defects create leakage and promote dystrophic calcification of the pulp. And you can see that in this case. Here's another case with a calcium hydroxide pulp cap, calcification of the pulp, as you can see here in this mandibular molar. So what about MTA though? An experimental treatment with MTA, what we see in the dog model, and the slides I'm going to show you from Dr. June at Loma Linda. Here's calcium hydroxide, no bridge formation, just inflammatory cells at 2, 4, and 8 weeks. We see some bridge formation at 8 weeks. With MTA, what we see instead is we see bridge formation at 2 weeks, solid bridge at 4, thick bridge formation at 8 weeks in the dog model. In fact, a study in the Journal of the American Veterinary Medical Association comparing MTA pulp capping and pulpotomy procedures with calcium hydroxide and MTA, here are the success rates. 92% for MTA in a dog model. So in experimental models with Pritford and Turbinajad and Dr. Backlund, they had 3 monkeys. And here's the experiment. They accessed the 4 anteriors and either pulp cap with MTA or with calcium hydroxide. And after they placed the amalgams, these animals were sacrificed at 5 months. In the MTA specimens, what they saw was bridge formation in 5 out of the 6 teeth. And I apologize, this color here is just shot. It's, sorry about that. And what you have to do is you have to protect those pulps from microorganisms, Staphylococcus right there. And this is the new classic study Dr. Takata showed. This is Mentes, is a double-blind clinical trial in multi-centers done in Germany comparing MTA with calcium hydroxide. Success rate 80% with MTA, 59% with calcium hydroxide. Calcium hydroxide is over. It's not a pulp capping material of choice anymore. Certainly MTA is. So what happens when I have a pulp exposure here? What happens is I just killed all the odontoblasts in that area. I have to get new odontoblasts. Where are they going to come from? Well, there's some stories about where they come from, and there's a lot of literature involved. So I'm drilling this area out. Here comes my handpiece, and I perforate this area. These odontoblasts are dead. They're gone. Where are the odontoblasts going to come from? They come from the center of the pulp. And what are they? Well, they're called different types of cells, and these will have to migrate from here to that perforation site to start laying down reparative dentin. And the cells that have been posed as the cells that create reparative dentin in these traumas are dental pulp stem cells. Well, the bottom line is, I agree with Dr. Ricucci. He's looked at his SEMs and his histological stains, and guess what? They're basically fibroblasts. So fibroblasts come from that center of the dental pulp, migrate to that area where the trauma occurred, where that exposure is, and become odontoblast-like cells that lay down reparative dentin. Here's a lady who's 50 years old at Dr. Ricucci's practice. Here's a pulp exposure. Here are 2 exposures, and they were repaired with MTA. He took the MTA out. You see reparative dentin formation there. And here's that same case at 7 months with complete bridge formation. So for pulp capping with MTA, you want to use a dental dam for isolation. And you want to use a surgical field microscope. There's no question about it. And I recommend a caries detector dye and sodium hypochlorite for your hemostasis. Hemostasis is very important. Again, very diagnostic as well. I also cover the teeth with a large amount of MTA. Not a small area, the whole area. Because when you're cleaning out caries, you can't tell if there's bacteria still in that surrounding area, even if you're using a caries detector dye. We were doing it in a two-step protocol because we had slow set MTA back in the 90s, so we had to wait till it hardened, bring the patient back to put a final restoration on it. So here's that case I showed you with that young man. There's MTA placement with a wet cotton pellet over the MTA and unbonded photocore. Now, did I bring that patient back, take out the photocore, and then put in my final restoration? And photocore is a great material for restoring endodontically treated teeth. It has a modulus elasticity, the same as dentin at 18 gigapascals, compressive strength at 45,000 psi, and also it cures 9 millimeters in 60 seconds. No other material like it. Fantastic material. You should be using it in your clinical practice. No, I have no financial interest in that company. With one-step pulp capping, which we can now perform with our better setting, faster setting MTAs like retro MTA, we have the ability to place the material, let it harden, use a resin-modified glass ionomer, and then go right ahead and place a final restoration. This is the resin I use in my practice. It's a product from Japan. Excellent material, very predictable, high bonding strengths, very simple to use. Or you can use Bond Force, which is another product from Japan. Superior materials. These are the Rolls-Royce materials in bonding as far as I'm concerned. So here's a 28-year-old female, small exposure over here after caries clean out, but notice the MTA. I place a big thick layer of MTA against the exposure site and also the surrounding dentin because I don't know how many bacteria are still embedded in those dentinal tubules. Again, here, a 30-year-old female with 2 exposures, and you can see them here. That's after sodium hypochlorite hemostasis, and you'll see a thick layer of MTA being placed over the exposure site and the pulpal roof. So let's look at these cases that were all diagnosed for root canal treatment for me. They turn out to be all living teeth. And take this one case. This is a 12-year-old boy. Look at this. You can actually, it looks like some thickening of the PDL here. Pulp test under cold was normal. Normal vitality. Thick layer of MTA, 2005. And here we go with the final restoration. Here's a recall on Mikey at 10 months. And we just got Mikey in for recall at 9 years. And this is CO2 normal, although we have some calcification here. That's reparative brick formation. That tooth is vital at 10 years. Would have been a root canal in most instances. 7-year-old female. Look at these open apices. Here she still has her deciduous teeth right here. So that was back in 2000. I think that was it was 2005. So there's a 3-year recall and a recall when she's in orthodontic training here. She's got her braces on. 7-year review. Look at that apex from here to here. Apexogenesis completed because we maintain pulp vitality. And again here, this is a 26-year-old female. You see the pulp exposure there. And there was a question from the audience about pressing MTA into the pulp. It doesn't hurt the pulp. You can compress it. It will not hurt the pulp as long as it's not irreversibly inflamed. It really has no effect on it. You don't want to physically push it in there as hard as you can, but if it goes into the pulp, I have not seen any poor outcomes as a result of having MTA pushed into a pulp that's vital. Here's a final restoration on her, and here's a recall on that young lady at 7 years and 10 months. This was a patient who was 12 years old, but it was my dental assistant's son who had a toothache the night before. So we brought him in, and he had a toothache. We anesthetized him. We cleaned this tooth out. Here's how he presented clinically. And we went ahead, used the caries detector dye, and here's the exposure. It started bleeding pretty good. But we left sodium hypochlorite on it for 10 minutes, and it started to stop hemorrhaging. And here it is. After 12 minutes or so, no hemorrhaging. So there's my diagnosis. The diagnosis is reversible pulpitis because it stopped bleeding. And it's usually about 10, 12 minutes. If it doesn't stop bleeding then you misdiagnosed it. we went ahead, placed MTA, and this was in the old days, so we had gray MTA only, over the exposures and the entire pulpal roof, okay? And here's that big blob of MTA with a bonded restoration, and here's some recalls. This kid was 12 years old when I treated him, 6 years, 6 months. And now, believe it or not, there's a 13-and-a-half-year recall. He's now a soldier in Iraq fighting for the U.S. Army. But that was the best recall I could get from him. But it's funny as you watch these patients grow up. Oddly enough, we performed a pulp cap on the opposite side. And here's a pulp cap on the opposite side with a 9-year recall. So here's one patient with 2 pulp caps. This patient was in his 20s. And review these quickly. Same patient, opposite sides, 2 second mandibular molars. Here's recalls of both those at 1 year and recalls of both the same teeth at 10 years. CO2 normal, normal function, asymptomatic with living pulps using MTA. This was the first MTA pulp cap I performed. What happened was I performed a pulp cap with a hydrophilic resin on this young girl who at the time was 14 years old in 1997. And here's how she presented. So I performed a hydrophilic resin pulp cap, and I had 2 exposures here. So I did it with photo bond and a composite restoration. She came back a month later and she was symptomatic. Dr. Bogen, this thing's really starting to hurt. So I cleaned it out, and here's how she presented. And it looked like it was almost starting to form a lesion there. So I went ahead, I cleaned it out, and I was using astringent, I think, as my hemostatic agent rather than sodium hypochlorite, and you can see the staining from the astringent. Finally, when I cleaned out the whole composite, now I had 3 exposures, and I had quite a bit of hemorrhaging. But after 10 minutes, I had hemostasis. And there's sodium hypochlorite, and there's my hemostasis. My diagnosis, reversible pulpitis. So when I had placed dark MTA over there, wet cotton pellet, and photocore, which is not bonded, because that's what I was using back then. I didn't have a quick set MTA. So we went ahead, placed a final restoration. And here's that case with the final restoration back in 1998 in February. Here's a recall of her 5 years and a recall of this young girl at 7 years, 6 months. And a recall with a new restoration at 13 years, 8 months. I talked to her recently. She's up in Northern California, promised to come in for a recall, and when I do get that recall on her, it's going to be close to 18 years. Young lady's 15 years old, diagnosed for root canal treatment. Her parents said to me, Dr. Bogen, we don't want our daughter to have root canal treatment. I tested the tooth with carbon dioxide ice, and it was vital. 1997. Was I going to use a hydrophilic resin? No. I don't like hydrophilic resins anymore. They weren't working for me back in the late 90s, so I chose to use MTA. Here's a 6-year recall with normal vitality, 7 years, 9 months, 14-year recall, and I had her in for a recall just at the beginning of this year. Here's a 16-year recall on a pulp cap with MTA. Normal vitality, normal function, and what's more amazing is the restoration that I placed is still there and functioning. So these hydrophilic resins that we have, I use the Japanese products, Kuraray from Japan, and they're amazing. I mean, 16 years of function on the restoration, 16 years of function on the pulp cap. It's a tribute to the technology that we're seeing in dentistry. Our pulp caps exclusively for young patients? Not really. This is my colleague. He's an endodontist in Pasadena. And he came into me and I tested his tooth. It was vital. Well, George, then I don't need a root canal. Yeah, you probably don't. So let's clean it out. 51-year-old male. MTA pulp cap. Look, a large amount of MTA. You can't see it on this because it's the screen is not very good. And I'll excuse this projector for that. Here's a 15-year-old female, takes her braces off. Look at this decay, but you get an idea how we approach these cases. Here's the radiograph. Here's the decay out of the caries detector. Caries clean up. Hemorrhaging control. And you can actually see the pulp. Here's your pulp sitting right in front of you. It's not hemorrhaging. That's a vital pulp. Large aliquot of MTA, wet cotton pellet, and a photocore temp. I'll have that patient back. But again, all these cases, deep caries in patients where you use the caries detector dye. And here, what can you see? Reparative dentin. That's a vital pulp. So place MTA in a large aliquot on the axial wall and to the top. Here's the temporary, and here's the final restoration, and a recall of this patient, I believe, at 6.5 years. So I'm not intimidated. As long as I can get hemostasis when I have pulp exposures, and that cold test was normal, any of these cases, it doesn't matter how big the exposure is or how many exposures I have, I know I can get predictable results using MTA as a pulp capping agent. Again, if it's hemorrhaging like this and you get hemorrhage control like that, then you can place a large amount of MTA over that exposure site and get control. So hemorrhaging control. Open apices in this young man right here. 12-year-old. Look at this closure of the apex. And here's that recall. And this is at 10 years. One thing you have to be aware of is necrotic tissue. Both these have necrotic tissue. You have to remove it. If it's not bleeding, you must remove it. One of my postgrad residents, this was his case. He didn't remove me. He showed me the pictures. And what we had from Dr. Choi was, here's the MTA, and here we see a periapical lesion. This became necrotic. So you got to remove that necrotic tissue. So here's a case of mine. This tissue here is probably necrotic. You want to be able to remove that. And that's a miniature pulpotomy. That's all it is. And here's a recall with a large aliquot, again, of MTA right over there. Okay. Let's very quickly, I'm running out of time here. We'll talk about MTA pulpotomy. If you have patients that have recurrent caries all over their mouth, don't consider pulp capping. Go straight to the pulpotomy, because they're going to get caries again, so be more aggressive in patients like that. In California, we use something called formicreosol to embalm teeth. It was grandfathered in California. A lot of pedodontists still use it. Horrible stuff. We don't recommend using it because it's carcinogenic, cytotoxic, and genotoxic. And here's a case of a 12-year-old boy with a fractured cuspid, tooth number 1-3. And what we perform is called a Schweck pulpotomy. So that's MTA placed after we remove 3 millimeters of pulp with a high-speed diamond round burr, sodium hypochlorite hemostasis. And you can see this open apex right here. And on recall at 1 year, you can see that apex closing. So you get apexogenesis in these cases, and that's basically what we strive for. Because when you try to preserve that pulp, these cells here at the apex, these are known as scap cells, or well said, you can call them stem cells of the apical papilla. And of course, stem cells are the body's repair tissue, the backup tissue that we have when some organs fail. These guys step up and replace that tissue with something else that's functioning. And here's a case from Dr. Rowe again of a young patient, 7 years old, with open apices on this particular molar, number 3, 6. And here's an MTA pulpotomy where she actually pressed MTA into the canal system. And we have open apices here, but if you watch this on recall, you'll notice that at 1 year, these apices close. And that's what we're trying to do, is get maturation of the root, because that strengthens the root and adds to the retention of the tooth. Here's another case from Dr. Buscher in Germany. Young girl, 10-year-old girl, broke this tooth off in a skating ring. She isolates the tooth. Here she's got 3 exposures. She goes ahead, takes out the roof of that MTA, places MTA into that pulp chamber. Okay, so she's providing a Schweck pulpotomy. The segment was glued back onto the tooth. And here's the case at 4 years. And then she had braces, but when they took the braces off, they broke the segment off, so they had to put a composite there. And here's a composite which was placed on tooth number 2, 1. But look at this. This is an open apex when the accident happened, and here she is 7 years later. And look at that reformation of the apex. You've got apexogenesis. And briefly, I have one very good case from Germany as well, from Dr. Holzmann. Look at this apex. That's a size 400. Another trauma case, a younger patient, 7 years old, MTA pulpotomy. Okay, a Schweck pulpotomy. He went into the pulp chamber here. That's MTA, that's a composite. Recall here at 2 years, and the tooth stained, because MTA stains. So he went back in, took out the MTA and the composite, bleached the tooth, placed a restoration over the dental bridge, because there's dental bridge there. And here's that case at 4 years. Now look at this. From this to this in 4 years. That's apexogenesis. That's what vital pulp therapy offers our younger patients. Maturation of the tooth and strengthening of the tooth, and they keep their tooth. It's wonderful. On small kids, these type of cases, you're going to have the deciduous tooth number 11, or excuse me, L, that's L. I use MTA, use a flowable resin modified glass ionomer, and photocore. And I see I'm going to do this for 2 more minutes, and I'll just finish up here briefly. And these are all open apices in patients that are 12, 7, and 18 years old. And here are the cases at 2 years. And what you see, and if you can't see it here because it's not very clear, is all these cases have open apices. And what you see at 2 years here is a closed apex here, and a closed apex on this patient 4.5 years later. And the last case to show you here, this is from Dr. Lindemann. He's in Illinois. And this is an MTA pulpotomy case with open apices and a recall of that case at 7 years with normal function, no periapical pathosis, and the patient's happy. So MTA, in conclusion, is a bioactive material that really promotes biological tissue repair in endodontic surgery, in perforation repair, in canal obturation, and also in vital pulp therapy. And here we are back in Patagonia, and my wife and I were there, I think it was March, and we took a hike. We wanted to see those 3 towers. And again, a beautiful area. And here are those, the Tres Cuernas, and surrounded by beautiful lakes in Patagonia, and areas where the llamas graze. And they also have a lot of mountain lions that they are predatory on those llamas. And here is the river coming through, and you hike this one here. It takes you 1 hour to get to here. It's huffing straight up, huffing and puffing all the way. And then you go through a forest for 2 hours. And then finally, the last hour, you go straight up the hill here. And there you are at the 3 towers. And this place is magnificent. This is a really beautiful area of the world. And if you ever have the opportunity, it is a hike of a lifetime. So thank you very much, and kamsahamnida.